Hi, I will be discussing how nurses can make uh, smoking cessation a reality using Watson's grand theory of caring with a transpersonal approach. Watson's theory has a unique ability to help provide care for patients on a deeper level. The nurse can care for a patient's mind, body, soul through transpersonal caring relationship instead of treating the patient like an object and distancing themselves from their experience. The nurse first needs to understand and apply Watson's 10 curative factors while explaining the risk factor that comes with smoking to help them quit. This will show that this will show the patient why it's important for them to quit and be able to have the nurse understand the motivating factors on why the patient would want to quit and what's holding them back from quitting. So, Watson's 10 character factors are 1. Forming selfless human value systems, and 2. Instilling hope slash faith, 3. Cultivating sensitivity for self and others, 4. Developing a helping and trusting relationship, 5. Allow for promotion of all feelings, 6. Using problem solving for decision making, 7. Promoting teaching slash learning, 8. Promoting a supportive environment, 9. Assisting with human needs, and 10. Allowing for divine force interventions. So, the nurse needs to use these factors with a transpersonal approach by building an authentic therapeutic relationship using love, compassion, and care so the patient can respect their advice when discussing different interventions to contribute to their cessation of smoking. The nurse can also gauge where the patient is at on a motivational level and assess how close the patient is to making specific changes in their lives in order to have them quit smoking. And this is really important because um, the nurse needs to gauge this in order to see if smoking cessation is a reality for this patient. Because if a patient doesn't want to quit or doesn't want to stop smoking, um, the reality of them to quit smoking will become that much harder or virtually impossible. So, Garcia Gomez, in her research uh, article published in 2019, talked about brief advice. And brief advice can be used to help individuals stop smoking. The term brief advice refers to a strategy that impacts people's motivation to quit smoking, seek treatment, or reduce the consumption of cigarettes through a single intervention. Compared to no intervention of any kind, brief advice has been shown to increase the frequency of quit attempts. Brief advice significantly increases cessation rates and is highly cost effective. And that last part, Zwar, in his research article published in 2020, he stated that the brief advice significantly increases cessation rates and is highly cost effective. So Lancaster instead, in their research article published in 2018, showed that the results of individual counseling studies showed that patients who had a history of smoking and participated in this intervention could increase the chances of quitting between 40% and 80% compared to minimal support. This means if 7 out of 100 smokers managed to quit for at least 6 months using the sort of brief support given to the control groups, then between 10 and 12 would be expected to be successful after having counseling. And then later in that research article, it was judged that the quality of this evidence was high for this intervention. It was also predicted that having more intensive counseling support, for example, more sessions, probably helps more, but the additional benefit is likely to be small, and again, was of moderate quality because the size of the benefit was uncertain. So back to Swar in his research article published in 2020, a combination of behavioral support along with pharmacotherapy to treat nicotine dependence maximizes the chances of successful long-term cessation. So a combination um, combination nicotine replacement therapy, or varenicline. I think that's how I'm saying it right. Varenicline are the most effective forms of pharmacotherapy. In Garcia Gomez's research article published in 2019, it showed a review of 52 studies with a total of 19,488 participants, provided high quality evidence for the benefits of combined pharmacotherapy plus behavioral treatment compared to usual care, brief advice, or less intensive behavioral support. Behavioral therapies were one of the first psychological treatments that proved effective in smoking cessation, and others began to complement the practice with self-observation, relaxation techniques, stimulus control, and gradual reduction of nicotine and tar intake. So we see here that the first intervention that is shown to prove to help smoking cessation is um, brief advice, and then you have individual counseling, and then you have behavioral therapy with a combination of pharmacotherapy. So these are the three interventions that I was using and found support on to show that this would help patients who suffer from a smoking addiction to quit and make this a reality for them. So my theory was perfect in addressing the smoking cessation, and I'll show you why. Because nurses can make this a reality, promoting teaching / learning when providing brief advice for the patient. Patients can learn why smoking is counterproductive to their health, and what interventions will help them quit. The nurse is able to create a supportive environment by reaffirming that all the patient's feelings are welcome to be expressed. This helps the patient get to the root cause and the debilitating factors that prevent the patient from quitting. This leads to a trusting, authentic relationship being built that can lead to the nurse referring the patient to behavioral counseling or behavioral counseling with pharmacological interventions. This will lead to more patients being educated about the risk of smoking, more patients believing / taking action to quit smoking, and producing a program where patients are quitting with less relapses. So there was sort of a balance here too, while I was finding evidence for patients who was it was shown that it's possible to quit smoking, but then I also found some conflicting information, and we'll go forward with this. So in Garcia Gomez's research article published in 2019, it showed that combining pharmacological treatment with behavioral interventions doubles the probability of success of smoking cessation. Many clinical guidelines in several countries recommend cognitive behavioral intervention together with the administration of the first-line drugs, that is NRT, bupropion, and varenicline. Varenicline, I think. And so, furthermore, in this research article, something that conflicted my findings is that these interventions work well in the short term, but long term, the abstinence rates are disappointing. There's a new wave of therapy called the third generation and has shown promise during abstinence trials, but it still needs more evidence of its effectiveness. There must be more research done that targets the root causes of smokers failing to abstain from smoking. This can be further studied through therapy and other behavioral treatment in order to see what is causing individuals to lean on smoking. Is it for coping mechanism? Is it a coping mechanism? Is it to relieve stress, pain, anxiety, or different things like that? So more studies need to be done. And so some implications I had here for nursing is that the nursing practice should have everyone be screened for a history of smoking, and then if they do have a history of smoking, they should be properly educated on what intervention they can take to stop smoking. So within this screening, they will be having they'll be assessed on their motivational level if they've already tried to stop smoking, and if they want to stop smoking, because this will give the nursing a gauge if they want to stop smoking and see how we can make this a reality for the patient versus another patient who comes in, has a history of smoking, doesn't want to quit smoking, and has never tried. So we can see which um, in the two different situations, you can see which one or which person is more likely to quit and more likely to have this become a reality for them. So it's seen throughout literature that these patients will most likely engage in cost-effective interventions if they do decide to quit. So brief advice interventions should be used in assessments when a patient has a history of smoking and still continues to smoke. This can um, allow the nurse to assess the patient's level of the motivation, like I was saying, and educate the patient on proper interventions that best fits the patient's situation. Um, because if a patient is not willing to adhere to individual counseling or behavioral counseling within the form of pharmacological treatment, then maybe brief advice is the best intervention for them right now. It's not the best in the long term, but we've seen that a brief advice intervention is better than no intervention at all. So I think if we focus, as far as the nursing practice, if we as nurses focus on the patient's problems and what specific problems or obstacles that are in the way of having them quit smoking, we can address this, and then we can have the patient experience smoke or abstinence from smoking if that is a reality they choose to have. And some questions that I think needs to be raised for future research is how long do certain interventions last in order to meet the abstinence goal of about 10 years? What interventions are best for long-term smoking cessation? How can we as nurses contribute to a patient's abstinence with smoking? Thank you.